Now we are going to discuss tricuspid regurgitation. Now before we go to tricuspid regurgitation, we see the waveform in the jugular venous pulsations. So what is the waveform? So you see it has 3 positive waves and there are 2 downwards or negative waves. The first upward wave, this is called A wave. This is because of the atrial contraction. The atrium contracts and the pressure rises in the atrium, and this pressure is reflected in the venous system as A wave. And then when the atrium relaxes, that is the atrial diastole starts, the pressure in the atrium starts dropping suddenly. So we have got a negative wave which is called X descent. This X descent is interrupted in between by a small upward C wave. This is because of the tricuspid valve during a ventricular systole. When the ventricular pressure rises, the tricuspid valve is pushed backward and the pressure in the atrium rises slightly, producing a small C wave. And then you've got after the X descent, there is a passive filling of the atrium resulting in a rising atrial pressure, which is reflected as a positive V wave. And then the ventricular diastole starts, the tricuspid valve opens, there is a rapid filling of the ventricles, and the pressure in the atrium drops as Y descent. Now what happens in tricuspid regurgitation? That patient, the heart, when it goes into systole, the pressure rises in the right ventricle. This pressure is transmitted through the regurgitating blood into the right atrium. So we see actually a big CV wave. The C wave, which is produced by the tricuspid valve moving backward. When there is an incompetent tricuspid valve, the blood moves backward from the right ventricle into the right atrium. So this pressure rises. And at the same time, the atrium is being filled by the blood which is coming from the vena cava. So there is a big wave which is called a CV wave, because in this C and V wave are fused and it's difficult to clinically recognize. So with each systole, you find a big CV wave in the neck. Now tricuspid regurgitation, most of the cases are because of a secondary tricuspid regurgitation. The primary lesion is not in the valve. Almost 90% of the cases are secondary tricuspid regurgitation. The 10% are only the primary disease in the valve or valve apparatus. So what we see in secondary tricuspid regurgitation, this valve is structurally normal. The right ventricle is dilated. There may be a dilatation of the ring sometimes, but it's the RV which is predominantly dilated. The RV systolic pressure, as it starts rising, it starts causing regurgitation. Pulmonary hypertension, RV infarction, Eisenmenger syndrome, and congenital conditions are other reasons. And now we see other reasons for primary tricuspid regurgitation. That is, we see the reasons for primary tricuspid regurgitation. That may be rheumatic heart disease, the most common. Then we may have infective endocarditis, especially in patients who are using intravenous drugs. Epstein anomaly is a congenital condition in which the valve is abnormally placed. Carcinoid tumor. Prolapsing tricuspid valve, as we see the prolapsing mitral valve. Connective tissue disorders like Marfan syndrome or similar conditions which can cause laxity of the connective tissue. Radiation injury, papillary muscle dysfunction, which can occur in infective endocarditis and sometimes in ischemic heart disease or sometimes in cardiomyopathies. Then we may have pacemaker leads which do not allow the valve to close or the valve leaflets to co-opt properly. Then drugs like methotrexate, phentermine, and right atrial myxoma, they can all result in tricuspid regurgitation as well. Now the statistics show that it is seen in less than 1% of the patients. There is no sexual or racial differences. However, there are some differences in the etiology with the age group. Patients who are younger, they tend to have Epstein anomaly because of congenital conditions. Children who are more than 15 years old, they tend to have rheumatic heart disease as a reason for primary tricuspid regurgitation. And keep in mind, tricuspid involvement rheumatic heart disease is not isolated lesion. There may be mitral or aortic lesions present as well. Then patients who are adults, they may have it because of the heart failure, it may be because of the carcinoid tumors, or it may be because of the infective endocarditis. So the etiology varies according to the age of the patient. Now what happens? The RV in inspiration widens further. There is negative interthoracic pressure, the venous return increases, the RV dilates. There is further stretching on the annulus. So in inspiration, RV dilates, the annulus dilates, and there is more tricuspid regurgitation. There is volume overload, which leads to hepatic congestion, the ascites, and the edema formation. Now the symptoms are, generally this lesion is very well tolerated for a very long time. Patients who present with symptoms, the symptoms are because of decreased cardiac output. Since the left-sided cardiac output depends upon the right-sided cardiac output. In tricuspid regurgitation, most of the blood is regurgitating back. Instead of going into the pulmonary artery, which is slightly high pressure vessel, then the right atrium, the blood moves back into the right atrium. So the right ventricular cardiac output drops. So the left ventricle, which is ahead of right ventricle in circulation, the venous return to the left ventricle through the pulmonary veins is reduced, and the cardiac output to the left side also falls. So the patient may have symptoms because of decreased cardiac output. There may be fatigue, and because of the pressure transmitted backward, patient may have anasarca. There may be abdominal discomfort because of the hepatomegaly. Patient may have abdominal distension because of the ascites. There may be neck discomfort in some patients because of the persistent distension in the neck veins, but only a very few patients report neck discomfort. There may be dyspnea on exertion. Patient may have orthopnea and PND, particularly if patient has associated other lesions. Physical examination, the general feature reveals the patient may have atrial fibrillation, that the pulse may be irregular. There may be dependent edema. Patient may have cachexia. There may be jaundice. There may be ascites. Patient may have pulsatile liver. Now the pulsatile liver in tricuspid regurgitation is seen in systole as opposed to the pulsation in the liver, which sometimes can be seen in tricuspid stenosis in diastole. So this is a systolic pulsation of the liver. The jugular veins are distended, and there is a very prominent CV wave, as we discussed earlier, and the Y descent is very sharp. So you can see it on neck veins. There's a big wave that suddenly collapses, and the veins distend and then it collapses. Then the precordium, patients who got associated pulmonary hypertension and those are without pulmonary hypertension, they have a slight difference in their precordial examination. So patient who got associated pulmonary hypertension, there is a pan-systolic murmur at lower left sternal edge, that is in the lower left fourth intercostal space, and there may be a loud P2 if patient has pulmonary hypertension, and if the heart is failing, patient may have S3 and S4, so there may be an S3 gallop in these patients if the right heart is failing. Patients who got no pulmonary hypertension, the murmur is low intensity and is usually seen in the first half of systole, while in patients who got high pressure, the murmur is usually seen throughout the systole. So this is a pan-systolic murmur, this is an early systolic murmur. Differential diagnosis includes atrial fibrillation for any reason, for example, thyroid disease or mitral valve disease or any other disease. The patient has to be differentiated as the patient is jaundiced with distended liver. It may be distinguished from biliary disease, cardiac cirrhosis and congestive hepatopathy, cor pulmonale, dilated cardiomyopathy, Epstein anomaly, Eisenmenger syndrome, heart failure, intestinal carcinoid tumors, and mitral regurgitation. These are the differential diagnosis of tricuspid regurgitation. Now, when we investigate on ECG, we find that there may be incomplete or complete right bundle branch block. There may be atrial fibrillation. The chest X-ray may show a non-specific cardiomegaly. There may be enlargement of the right atrium. There may be pleural effusion. The ultrasound may show the liver is congested and enlarged. There may be ascites present. Echo shows the severity of the tricuspid regurgitation. We can see the right ventricular function and the right atrial size, and we can also see the pulmonary artery pressure in echo. And then cardiac catheterization usually is not required, but it's done when we are planning surgery or we are looking for other associated lesions or looking for the associated coronary artery disease which may be present in these patients. So if there is systolic pressure which is less than 40 millimeters in the right ventricle, that favors this may be a primary tricuspid regurgitation. But if the right ventricular systolic pressure is more than 55 millimeters, this is most likely a secondary type of tricuspid regurgitation. Now the management. The management is the primary tricuspid regurgitation generally requires bioprosthesis. You have to replace the valve. But in secondary, you can go for the treatment of the underlying cause. You may control the underlying cause, for example, heart failure medically. But if it's not responding and the patient has symptoms, you may go for surgery, which usually is annuloplasty in conjunction with mitral valve surgery. For example, you can go for annuloplasty in association with mitral valve surgery if there is a mitral valve disease. So you can go for annuloplasty and mitral valve surgery. If the mitral valve surgery is done, the pulmonary artery pressures or pulmonary pressure, they start dropping, pulmonary hypertension decreases, and the tricuspid regurgitation, that's why it decreases. So you can only go for annuloplasty. The patient may not require tricuspid valve surgery if the TR is mild and the tricuspid annulus is normal. So in secondary tricuspid regurgitation, if the tricuspid regurgitation is mild and the patient doesn't have symptoms, you may not require surgery, particularly if the tricuspid valve annulus is of normal size. Now, patients who've got infective endocarditis, that is in intravenous drug users, if there is endocarditis, a valvectomy may be performed, that you remove the valve and you place a new valve. And patients who've got valvectomy, they tolerate the valve removal very well if there is no pulmonary hypertension. If there is pulmonary hypertension, then the patient starts having symptoms earlier. But if there is no pulmonary hypertension, removing the valve does not cause symptoms, and the patient tolerates this procedure very well for a very long time. So that may not be a problem removing the tricuspid valve in those patients. So this is about the tricuspid valve regurgitation, and next time we will discuss the other valve of the right side of the heart. Till then, goodbye.